the terrific scholar who is doing a fantastic job. So let me get started. This is a very ambitious plan that I have here. There are a lot of topics that I would like to touch on. I hope that you can bear with me, and I would love to hear your questions as well. These are the kind of things that I want to go through, who are we and how are we growing. I think that is critical to have insights as to who we are, you know, in order to tackle those issues, disparities in access to and quality of care. Some, after many years of being in Latino mental health care, to tell you, boiled down to the three main issues from my perspective that we ought to be looking at. The role of prevention on reducing disparities, and then to tell your story as to what's going on in California of a unique opportunity, and to focus on prevention and early intervention, and some of the work that we at our Center for Reducing Health Disparities have been doing, working with the most underserved communities throughout California, including Latinos, seasonally employed farm workers primarily. And then to share with you a little bit about the investment that California is making on prevention and early intervention. Okay, but let me start with this. Just imagine working 10 hours a day, including weekends, earning nearly minimum wage rates in dead-end jobs for 15 years, being responsible for a family of 4, living with your family in one room, sharing an apartment with other 9 people, and being stuck in what was quoted as a permanent underclass of the poor, the unskilled, and the uneducated. I don't know what that would do to you, but this is what it does to Juan Manuel Peralta. This is the cover page of the New York Times back in 2005. And here you have Juan Manuel Peralta, who is a Mexican immigrant, as there are so many, who made it to New York. And he was talking about what it meant to him after being 15 years in the U.S. and being stuck in the bottom of the employment ranks. This is a quote that I'm very touched by it. I've been here 15 years, and if I die tomorrow, there wouldn't even be enough money to bury me. No tendría dinero ni para que me entierre. And here you see one of his sons. He has a couple of kids, in this bunk bed, doing his homework, and in an apartment with one room. So just think about what something like this would do to you. What it does to Juan Manuel Peralta, and it does to so many of our immigrants, to come to the States. This is one of the impacts, and it doesn't take for me too far, as I was, reading this report to at least hypothesize that Juan Manuel was depressed, and that he was in a situation, an impossible situation. I decided to share with you this particular case because I think that it captures the complexity of the issues that we are dealing with and that I will be touching on. And certainly, this, what used to be a mobile group coming back and forth from Mexico to the US, something that with the lack of immigration reform or a policy, haven't been able to do that. Also, I want to emphasize, what this has to do with a vicious cycle that we ought to, when it comes down to mental health issues and substance abuse issues, that we ought to look at. This comes from the World Health Report 2001, that the World Health Organization, the very first World Health Report totally devoted to mental health issues, and this is what they call the vicious cycle, the vicious cycle of poverty and mental disorders. This is one of the things that we ought to be looking at when it comes down to Hispanic populations. And it goes like this, that poverty, low education, and employment is related to higher prevalence, lack of care, a more severe course of mental and substance abuse disorders. In turn, it has an economic impact, you know, lost productivity, loss of job, and then this goes back. So it is kind of a spiral, really, that is incredibly difficult unless we make a cut in this cycle to aspire to have economic prosperity. So if you are for economic prosperity, there are two incredibly important issues that you need to consider. One is access to healthcare when people need it, and the second one is access to education. Unless we have that, we will continue to be in these cycles of poverty that unfortunately I think that our populations are very much involved with. The other thing that we need to do is to connect dots. And one dot is that we ought to be looking at the Hispanic demographic trends. Another one is intergenerational issues. This has to do with how we are growing and how the way in which we are growing has an impact on our mental health, you know, and our health issues as well in general. The other one is that, as I said, in those problems, and then productivity and economic prosperity, how this relates to health disparities, and I want to put it right in the center, access to quality care. Because it's in the centrality of access to quality of care. And if we really focus our efforts on that, something that nobody cannot agree with, you know, regardless of the US, right now we are about 15% of the total population. California has the largest Latino population, 35%, and Texas is second. And currently, we account for 50% of the national population growth, and by 2050, we are going to constitute 25% of the US population. We continue to be very prolific, you know, and I wouldn't be surprised if that percentage even gets higher than what is there. High concentration of US Hispanic population and Mexico population along the US border. You know, Hispanic Latinos, once again, are the largest minority group. 2/3 are of Mexican origin, and that percentage is 84 and 83% in California and in Texas, respectively. High levels of immigration, 53% of all immigrants are Hispanic, like me, projected to reach what I just mentioned. 6 Mexican border states, you know, comprise 17% of Mexico population, and the growth in the Mexican border region exceeds the country. So those are statistics that ought to be given us a pause in terms of how to deal with these statistics. When it comes to Hispanics, what you have here is that these border towns right here capture 59% of the US Hispanics. No? So this is it for in terms of when we talk about Hispanics in the US. Here we are, you know. The other thing that I want to, looking at the crystal ball, is how is it that we are growing? And if you take a look here, this is the first generation. Those like me that were born in Mexico or in other countries come and now reside here in the US. And that peak around 2005 and now is coming down. And what is growing is the second generation, right here with the dots, and then the third generation, which is like one of my sons, you know, I have 4 kids. 3 were born in Guadalajara, 1 here in Fresno, and then my grandson, who is a 3rd generation, who was just born 7 months ago. And one of the things that I also want to bring to your attention, this is California's age pyramid. that most of the growth that we have right now is on the native born, as you can see here. Lots of kids, you know, second generation, and also lots, not as many, on the third generation. And when you take a look at our parents who are first generation, there are a lot of dynamics that happen between the first and the second generation. And as I will share with you based on some of our studies, these are issues that we ought to be paying attention to, because they apparently are associated certainly to health outcomes, specifically mental health and substance abuse outcomes. This is the Healthy Border 2010. I'm sure that they are working on the 2020. And just to bring to your attention that one of the issues, one of the priorities identified is mental health and substance abuse. This includes, it's a more kind of a generic umbrella that includes both of them. Let me tell you why. How many of you are in the mental health field and substance abuse? Most of you. So I'm sure that you know these statistics, but it is very important for me to touch base with you of why mental disorders, what we ought to be paying attention to mental disorders. And this is based on the collective wisdom of 3 decades of research that we have done or in the last, here in the US as well as in the world. Mental disorders are among the most prevalent classes of chronic diseases in the general population. You know, I don't know if there are 100 of you here, at least 50 of you either are having a mental disorder right now, you know, or had it in the past 12 months, or you had it in your lifetime. No one escapes mental illness, either in yourselves, in your relatives, or in your friends. No one escapes it. And yet, as I will tell you a little bit later, people just don't have it in their radar. You know, they think about with stigma, with fear. There is a tremendous disconnect that we all have to be working on, because between what we know about mental illness, and we know a lot, and what is it that population knows about mental illness, there is a tremendous disconnect. The other thing is that they are highly comorbid. You know, this is the rule rather than the exception. The norm is that they coexist. So people who suffer from severe anxiety also they can be suffering from depression, or people who suffer from diabetes or hypertension or arthritis or chronic back pain or cerebral vascular disease. You name it. There are many physical conditions, especially chronic conditions. They also suffer from mental illness. So they are very highly comorbid. The other thing is, this is a very important story and with implications for prevention. Typically, mental illness have much earlier ages of onset than other chronic diseases. Do you know that by age 24, 75% of the mental disorders show up, they already started? By 24%, by age 24. This is something that Ron Kessler, the principal investigator of the National Comorbidity Survey and one of the national international authorities, called mental illness the chronic conditions of the youth. Because they happen early in life, and then they become very disabilitating, discapacitating. That's what, as I will tell you in a minute, happens with mental illness. The other thing is that only a minority with mental needs receive treatment, as I will illustrate this a little bit later. And also, this is something that has to give us pause, are among the most disabling of all chronic diseases. This is the global burden of disease, the landmark study that the School of Public Health, Harvard, with work commissioned by the World Health Organization, told us back in 1996. And this is, we have evidence trust evidence since then that when you consider the top 10 causes of disability, 5 are mental disorders. And you know what? Number one is depression. If someone suffers from a severe depression, it's going to be more with more disability than if the person suffers from paraplegia, for example, or terminal cancer. Isn't that something? Okay, so these are the key three issues that I was telling you. One is relevance, that mental health issues are largely relevant to the public. Certainly that happens with Latinos. Access to care, which is a big problem with Latinos. We have 3 decades of data that tells us the incredible underutilization of services by Latinos. Okay? So I'm hoping to discuss that a little bit more with you. The other one is that quality of care is a long way from what it could be. This happens not just with Latinos, it's with any especially ethnic groups here in the US. But with Latinos, this is even worse. You know, the Agency for Healthcare Research and Quality that publishes every year this National Healthcare Disparities Report. For 2005, 2006, and 2007, consistently they said that when it comes to access to care and quality of care, even though there are some gains for some ethnic groups, minority groups in the US, this situation has been worsening for Latinos, especially access to care. So we have to do something about this. This is not by accident, and it is unacceptable. We have to say it very boldly, and we need to get into this effort because this is unacceptable. These are preventable, many of them, and you know, it leads to unnecessary mortality. Okay? Just to give you an idea, these are in California the penetration rates of those who are medical eligibles and who use services. Just to compare, you know, Latinos are among the most underserved populations in California, along with Asians and Pacific Islanders. And this is for 2003-2004. If I were to show you a time series, you know, year after year, this has been consistently like that. We're hoping to do something in California to modify this. Let me share with you some data coming from a study that I did with Bill Vega that we call the Mexican American Prevalence and Services Survey. And what we did, these are the results, but what we are comparing here is our data here with the data that Maria Elena Medina Mora from the Institute, the National Institute of Psychiatry study that they did in Mexico City. And then with the National Comorbidity Survey, which is the norms that have been developed at the national level, Ron Kessler's, and we have a Hispanic sample in which they only interview people in English, not in Spanish. And then the norms, the national norms. Look at this. When you take a look at lifetime prevalence of disorders in these 3 studies, this is the story. The highest prevalence is in the nation. Almost half of the population suffer from one or more mental disorders in their lifetime. With Hispanics, you know, which are only English speaking, is even a little bit more. And this is compared to the samples in our study and the sample that in Mexico City. We use the same instrument, and we use a very similar methodology with this, so we can compare the rates in this across these studies. But listen, there is a differential here. So what really impacted us when we came up with the results back in 1998, excuse me, was that if you unpack, you know, if you disaggregate our sample by native born, the US born versus the immigrants, first generation versus second and third generation, this is the story. The US born approximate the rates at the national level, whereas the immigrants were very similar in rates to the ones in Mexico City. And if we unpack this even further, so we have the immigrants, short stay, with less than 13 years of arrival here in the US versus more than 13 years with the US born. Look at this incredible gradient. okay? And this is any disorder. So what happens if we divide by the different diagnostic categories? Well, this is the story. We have any mood disorder in blue, any anxiety disorder in red, and any substance abuse disorders in yellow. And one of the stories here is this tower right here in the US born. These are people of Mexican origin, adults 18 to 59 years of age. A study that was done in Fresno, California. It was, a probabilistic study based on the 4,000 plus that we interviewed. We were able to generalize to the over, at that time, over 300,000 people of Mexican origin in the county. And so the story is this one right here, this tower. When it comes down to alcohol dependence in the native born, there is this big flag, that is much higher than any other group. And this is alcohol and drug abuse and dependence. Alcohol dependence. Drug dependence, that I forgot to put it here, is the same thing. So this is a red flag, and I'm glad that Felipe is going to be talking specifically about substance abuse. But when it comes to second generation Latinos, this is one of the issues that we ought to be looking at. By the way, when we published our first study, a cartoonist that was working with Bill Vega, who at that time was at the University of Texas in San Antonio, sent us this cartoon. But this is not an isolated finding. Actually, what I just presented to you has been replicated over and over again with national studies like the one that the NESAR, this study that was done by the National Institute of Alcohol, NIAAA. And they had a huge sample, over 45,000 interviews, and they had a very big sample of people of Mexican origin. The same thing. What you have, this is in men, and if you take a look, the US born have sometimes 2 times, and even more, like in this case in drug abuse. It is what, 6 times higher, and then in this one is 9 times higher in the US born versus the immigrants. And this is, in women. And women tends to be, that ratio tends to be even worse. So there is something there going on that we ought to be paying attention to. And I think that it has to do with the intergenerational issues in which parents who are first generation sometimes don't even talk the same language than their kids. I'm sure that this is not news to you in terms of some of the dynamics that happen between the different generations. And I think that it is not by accident that we are seeing nationally that Latinas adolescents are at the highest risk for suicidality. I think that you are presenting some of that, perhaps. Yeah. So I won't get there. But these are just warning signs that we ought to be paying attention, that there is something going on in the dynamics of how we are growing, and that we need to address, and to address it in a very thoughtful manner. By the way, these are rates of service utilization in our study. These are people who were found to be with 1 or more mental disorders, and those who use services in the last 12 months. And the story is that 1 out of 3 of the US born, 1 out of 6 of the immigrants, and less than 1 in 10 of the migrant agricultural workers that we had in our sample received any kind of care. And we had a very comprehensive set of questions in terms of care. Specialty care, medical care, also what we call other professionals. That includes chiropractors, homeopaths, priests, nurses, counselors, And also we have the informal sector, like pulp healers, sobadores, hierberos, you name it. Okay, why is that? The other thing that I want to let you know is that when people get to the doors of services, they don't seem to stay too much in the services. Actually, the studies tell us that up to 75% of those who come for services don't return for a second time. Think about it. What kind of quality care can they get? Okay? Actually, Maya Alegria, who is the PI of the National Latino and Asian American Study, she said that only 57% of respondents in treatment in her sample say that they completed treatment. And the most number of visits is 1, and a median is 3 for both psychiatrists and psychologists. This is in a national sample with Hispanics. So what kind of a quality care can we get when people suffer from mental disorders? Of course, that should give us pause about, what kind of systems do we have in place that would invite and would be really engaging for these populations. It really has to make us think as to how we can better address these needs of these populations. When it comes to children, Latino children tend to receive mental health services through juvenile justice and child welfare, and more often than through schools or mental health settings. This is the main point of entry for Latino children. And in child welfare, Latino youth have poorer outcomes, fewer services, less likely to have plans for family contact, and more likely to be out of home placements. Actually, let me share with you this story, because I think that this is a warning sign for Hispanics especially. And this is, these are rates in California, but something similar is going on nationwide. And these are the foster care case laid by race and ethnicity through all of these years, right here. The good news is that foster care is on the down for African Americans and whites that look for Latinos. It has remained like that. One of the tragedies that we are observing in the last 20 years is that the family, that was one of our best assets, the intactness of families, parents, with children, is disintegrating with Latinos. If you take a look at the statistics in the last 20 years, unfortunately, the increase in single-led parent households has increased significantly. Right now, we are at 50%. So 1 out of 2 families, in which there is a dad and a mom, will end up split. There are other groups in which this is even higher, but this is something that we ought to be looking at, and this cries for having a well-articulated, cohesive youth policy on how to pay attention to our youth growing up. So with all of this information, there is this question: how can we transform services and supports to prevent high-risk behaviors and improve outcomes in Latino, and of course, other underserved populations? And please forgive me if I'm focusing on Latinos, but this also applies to many other groups. We are working very strongly with MOM, for example, in California, with Native Americans, with African Americans, and the story is very similar, okay? So there are just to share with you some key elements in addressing and reducing disparities. This comes from my colleague Lark Quine from SAMHSA. We need to have a planning process, data utilization and quality improvement. We need to know what to measure, when to measure it, and to have timely measurements so we will be informed in a timely manner, in a comprehensive manner as to what's going on. Also, restructuring services and supports to address the needs of underserved communities. We need to have some infrastructure building, targeted training and technical assistance. We have to deal with these disconnects, as I told you, in terms of the magnitude and impact of mental disorders in regards to how people think about these issues. And there is a tremendous disconnect. So public education campaigns, mass campaigns, have to be in place as well. And finally, champions, allies, and coalition building. Lots of coalition building, and I'm thrilled to see that here, Hector and Dr. Anders, you are, taking the lead in bringing these issues to this region, to this community, because we need to do that. We need to collectively put our heads together and head on, deal with these issues. If I just pay attention to, I focus on this one, on restructuring services and supports, these are some of the critical pieces that, in my opinion, ought to be looking at. Community-based partnerships, outreach and engagement, interface of primary and behavioral health care and co-location of services, adoptions of evidence-based and practice-based interventions, something that has to be distinguished and acknowledged that there is not enough science, especially with our communities, in order to know enough as to what's going on, and that there is a lot of wisdom, collective wisdom in these communities that we have to learn from. And then finally, prevention and early intervention and health promotion are key, as Rick mentioned earlier. We have this great opportunity now with the Institute of Medicine Prevention Report out. This past week there was this national release, and there is another IOM report that is coming up in perhaps in May. I'm a part of the work group in that one, and that is parental depression, the healthy development of children. And it is amazing how the literature is playing out as to we are neglecting what is happening with mothers who just had children, and the impact that has in children, and how with a little bit of investment, early investment, we can go long ways, because that's what the evidence shows us. I mean little investment, long-term gains that we can have. And so I hope that you have your antennas up when these reports comes up. So here, in terms of prevention, I love this. Yes?
Sorry to interrupt you. One of the big disconnects that I've seen, and I've worked with probably all at-risk, high-risk groups in about 10 years of service to El Paso. It's like we know what's wrong with the people, we know the stats, we've done studies. Then the academic world knows what they're doing and what they're studying. But when you try to get services for people at this level, there's a major disconnect between how people are addressed, how they're treated. I work with homeless clients right now, and if I'm not at the hospital when they're discharged, I will have medications given to them that need to be refrigerated, that are expensive. They're saying do a bubble bath, soak in Epsom salt. Just a very major disconnect between the people who do and the people who need.
Yeah.
And so I think better training needs to be done for social workers, case managers, doctors, nurses, because we might think we're the smart people, but if we keep getting all this money and we don't improve the numbers, then really how smart are we?
I totally agree with you, totally. And actually, I'm going to be touching a little bit on that as well, because one of the things that we have neglected as academicians, especially in academic health centers, is to forget to ask people what they need. And we very often make assumptions as to what they need, and then we are surprised when we find out that our findings are, not attractive to people, and then we don't have traction on our programs. And treatment adherence, and compliance are huge issues that we ought to be paying much more attention to. So thank you for bringing that up. So this is what George Albee, one of the fathers of prevention, tells us. John Gordon, a professor of epidemiology at Harvard in the late 50s, sat me down and said, "No mass disorder afflicting humankind has ever been brought under control or eliminated by attempts at treating the afflicted individual, nor by training large number of therapists. I never forgot his words and make my classes memorize them, because this is the essence, the whole spirit of public health. One does not get rid of mass plagues afflicting humankind. including the plague of mental and emotional disorders by attempts at treating the individual. You know, for years, I was attributing this quote to George Albee. Actually, a lot of people does. And then recently, I realized that it doesn't come from him. It comes from John Gordon. But the point is that especially with Latinos, I think that there are many reasons why we ought to be paying attention to prevention. Because I'm convinced, actually, that if we, like the field trees, that if we were to build a wonderful, available, accessible, appropriate, affordable services that is still many people wouldn't come. So, and one of the reasons is that we are on the waiting mode. It is come to us, you know, instead of going after them and really get active in terms of once again, asking directly from them as to what their needs are. So with that in mind, let me tell you that there is a role of prevention in reducing health disparities because improving health access, it is only part of the solution. And it's a very limited solution, very important. We shouldn't neglect it. But it's a very limited solution because these three reasons basically. Clinical care treats one person at a time. Intervention often comes late. I can tell you that with Latinos that is the case. They usually come to emergency rooms when they are falling apart. And the interventions tend to be 10 times more costly and definitely not as effective as earlier interventions. And then clinical care is usually sought after people are sick. This is kind of the fail first mentality. You know, you first get sick and then come, as opposed to health first. And there is a lot of data that indicates that it is good policy and good investment, actually, to get into the health first policy. Prevention and early intervention can make a vital contribution to current efforts to reduce disparities in health. By addressing the underlying factors that negatively influence health, prevention has the power to reduce the incidence of poor mental health and disability and premature death. Now I'm moving to the story in California. And to share it with you what's going on. It's exciting, let me tell you, because thanks to this proposition, which came to the voters, and it was a grassroots effort, it passed a little over 4 years ago, and it became the Mental Health Services Act in 2005, January of 2005. How many of you have heard of this Mental Health Services Act? Yeah. Not many of you. I hope that you do, and that you pull a fast one out of Texas also with something like that, like this. This is called it's kind of a Robin Hood measure in which what it does is that the millionaires in California are taxed 1% of their raw income. And this money goes to expand the mental health services system. You know, it's great. In California, we have over 40,000 millionaires. And some of them are very, very rich. I cannot help it but to share with you that one of those millionaires that is contributing significantly to this measure is Tom Cruise. Mental health services, these are some of the things in terms of the content. Expand mental health services, and these are things that Rick talked about, recovery and wellness. A stakeholder involvement, the idea is to go to people and ask them, what are your needs, concerns, how can we do a better job? And to really have a stakeholder input, also to focus on unserved and underserved. And there are 5 components in this particular act. One is community services and supports, basically treatment, education and training, something that we call capital technology. This is infrastructure building, and then prevention and early intervention, and then something called innovation. And I'm going to focus specifically on prevention and early intervention. These are some of the priority populations that have been identified, like underserved cultural populations, those experiencing onset of serious psychiatric illness, children and youth in stressed families, trauma, exposed individuals, children youth at risk for school failure, children youth at risk of experiencing juvenile justice involvement. Do you think that this have to have relevance to the populations that you see? I think that they are right at the heart of certainly the population that we see in California, and I'm sure that in your in those that you're facing as well. Some of the focus areas are disparities in access, psychosocial impact of trauma, at-risk children, stigma and discrimination, and suicide risk. One of the central goals of the Mental Health Services Act is the reduction of disparities, mental health disparities. And the question comes as to how do we do that? What are the problems that underserved communities experience and report, and how can mental health services better address the needs of underserved communities? And we need, obviously, we need direct input from underserved communities in order to do that. But this is not an easy work, as many of you, I'm sure, have experienced. And the reason is that many people are totally unaware of the potential benefits about it, not ready to participate in policy process, so there is distrust. People say, I don't see the gain, the benefits of doing that. Suspicious and distrustful of mental health services as well. And I love this quote. Go in search of people, begin with what they know, and build in what they have. I think that we ought to be doing much more of that, and to learn directly from the source as to what is of relevance to them, but not only about their needs and concerns. Learn about their strengths and their assets and their resources, and to honor that and say, you are a contributor to the solutions, because you are a very resilient person that in spite of the circumstances that you are living, you have something valuable to contribute, okay, and recognize that. So with this, I want to share very quickly something that our Center for Reducing Health Disparities was asked to do by the Department of Mental Health statewide, and that is to collaborate with underserved communities addressing prevention and early intervention needs through community outreach, engagement, and participation. Okay? There are a couple of reports that we just released last year. This one right here, the blue, and the yellow one. The blue reports, the results that we did with many key informant interviews that we did, as well as cultural broker interviews, and 30 focus groups with the most underserved that we could find in 10 counties in California. California has 58 counties, so we did it only in 10 counties because we were in a rush to inform back to the state as they were developing the guidelines, on how to release the resources to the counties. And then we developed this how-to guide on building partnerships, key considerations when engaging underserved communities under the Act for counties. Because counties, very often they would say, oh, we tried and we never get these populations. They are very hard to reach. Well, this is some help, and we have been doing quite a bit of technical assistance to several counties, and I know that there are several counties that have been using some of the things that we have here in terms of addressing these populations. So what were the goals? Well, to do outreach in these communities, to develop a community engagement process, so we really get direct input from these communities, and this is based on principles of community engagement, like respect and mutual trust, investment in community relationships, and to do it collaboratively with them. And then to solicit and gather input. We ask questions about, some ideas about prevention and early intervention ideas from these populations as well. These are the things that we did in terms of how we went about doing it. We identified specific underserved communities. We had 4 criteria, especially for the most underserved. And then we interviewed the informants, worked with cultural brokers. We did, as I said, 30 focus groups. And then this is of great importance to us. to provide feedback to communities about the impact of the information collected and policy and services. So when we came to them and we tried to build trust with them or be held by some of the community leaders who already have trust with them and said, if you give us information, this is what's going to happen with it. We're going to inform the state about this information and also the counties, and then we're going to come back to you and be accountable to the information that you gave us, which is exactly what we are in the process of doing. These are the 30 focus groups with specific ethnic groups, as you can see there. You know, other underserved groups. We did focus groups with LGBTQ youth, with foster youth, with young adults with juvenile justice history, and older adults, both in rural and urban populations. And also we did it with community-based providers that serve these communities. These are the key findings. Mental health problems, and in a minute I'm going to tell you what were the most prevalent mental health problems that the communities told us. Also problems accessing mental health care and the quality of services received. This one came up with a strong force, social determinants of health, such as poverty and discrimination, the lack of safety in the neighborhoods, you know, the violence. The parents were scared to death that their kids were going to get into drugs, you know, get into gangs. That was a very repeated kind of a story. And then issues of social exclusion, you know, how socially isolated many of these communities are. These are the specific concerns, and these come in rank, in order of importance. So first is issues of violence and trauma in these communities. Drugs, depression, stress, and suicide, and very quickly, just to share some of the voices and to bring you know, their voices to you, these are some of the things that they were saying. Where I live, everyone suffers from domestic violence. Many times in Mexico, you keep quiet because you fear that he will hit you again. Here, this is the country of opportunities where you have to speak. If you don't give yourself the opportunity to speak and tell people or report it to the police, he will continue to do it always. Drugs, but you do not belong. You are not Mexican, you are not American. You are discriminated because of the first, and you are discriminated because of the latter. If your opportunities are limited, you don't relate well to your parents. You do not fit with them, so you end up being what? Someone who suddenly accepts you and is a gang that is to make violence, takes drugs as an escape. Depression, I believe what is affecting a lot is the salary. For that reason, people are suffering a lot of depressions. Stress, what stresses us as parents is that we get home from work and have to deal with the children. You don't have time to have a friendship with your children. You are at work all day and you are tired, but we have to do work around the house. You don't have the closeness with your child. That breaks my heart, let me tell you. Suicide, yes, reaching the point of attempting against your own life due to ataques de nervios, and like you say, the desperation. You reach the point of attempting against your own life. We went after the community assets. We asked not only about the needs and concerns, but also we were very interested about their strengths and the resources that they have. So they identify as their assets, individual and community resiliency, traditional and spiritual healers, religious healers, informal and formal support networks, community-based organizations, and social service health programs. These are some of the recommendations that come from them, not from us. These are come from them. Things like programs to address social concerns, school and after-school programs, mentoring programs, support groups and group therapy, education about mental health issues, parenting programs, programs for youth exit in the foster care system, and those kids in the juvenile justice system, and also for the older adults. These are some recommendations coming from us, you know, based on what we learned in this whole process. Promote mental health, should give priority to the needs of the local community, and the prevention and intervention planning should involve community members, organizations, and advocates to determine community needs and to develop effective strategies for prevention. Also, an investment to the future, and that is to invest in building these ongoing relationships with communities, knowing that those communities are not going to go away. This is one of the waking calls that we at Academic Health Centers ought to be getting. That sometimes when we need communities for our research, we do kind of a safari research. Go and get the prey and get the heck out of there, and never to be heard again. We have to be doing much better than that, to really build partnerships with these communities so they would benefit right from the go when the questions, research questions are being formulated. Mental health care delivered when needed and in a timely manner can prevent the development of severe problems. Establishing and maintaining collaborative and trusting relations with community members, address past and present experiences of violence and trauma in the development and implementation of these programs, build on existing community assets and resources, and develop integrated community-based services that integrate mental health services with other social services. Intersectoral collaboration is key for these populations. Because the point of entry of many of them is not the health services, it's even less the mental health services. It is other services such as probation, police, as well as social services. Okay, just to share with you, this is a series of brief reports that we recently, just as I talked, put together as our attempt to be accountable to these populations. So what we did is to tailor the data that coming from the specific ethnic groups and to go back and tell them, look, this is what we heard, you told us. Did we get it right? You know, if not, tell us what else ought to be in here. And we do a little bit of matchmaking as well, because when we come to these communities and those who participated on the focus groups, we bring the county folks, you know, along as observers, and with the idea of getting them started on a relationship, hopefully an ongoing sustainable relationship, so these communities can benefit from all the goodies that are happening right now in their communities. We have gotten all of these reports, you know, with Latinos, with Native Americans, with African Americans, with the youth, the LGBTQ youth, with Hmong, and also we have one that is for all of them. And we did it in the simplest language what we could possibly do it. The one with Latinos, and all of them are full of quotes also, because we are very interested in sharing their personal accounts, you know, to bring their voices. So they speak, they are the ones who speak. By the way, we have translated some into this in Spanish, we have one in Hmong, and this general one is being translated to 6 threshold languages. And I'll be happy to send you the PDFs. This is for wide dissemination, and I'll be giving you, you know, the PDFs, Hector. So if anyone who would like to have this will be more than honored to do that. Okay, very quickly. This is what we are doing, you know, is to full circle from research to public policy and services to research. This is what we did. Our results were given to the state, you know, and we told them some of the things that we found. The state developed these guidelines so the counties could you know, follow the guidelines on how to engage with these communities and learn from them. And then whatever we learned, we put it in this specific language, going back to the communities. And my hope is that whatever we learn from them, as we come and approach them, and also from the counties, is going to feed us back into this circle that will continue, hopefully, be ongoing, so we can get it right, you know, eventually. There are several other slides that I would love to share with you. How am I doing the time?
Just a few more minutes, and that's so that we can open up for
Great.
50 minutes.
Great.
Discussion, and then we can go for a break.
Okay. Thank you so much for being diehards. These are just mental health investment in prevention, what is going on in California, seeking new approaches, partners, and providers to carry out this component. Public mental health approach, moving outside mental health service doors into the community, serving Latino communities in places with less stigma to lead to improved access and improved appropriateness of care. Major new investment with over 300 million on prevention and early intervention annually. You know, this is a great opportunity. How often do you hear that public health systems have money for prevention and early intervention? So we really hope that we don't mess up this opportunity, and there is a lot of collective effort in trying to make this as successful as possible. These are some strategies to address disparities, things like providing services in schools, integration of mental health in primary care settings to lessen stigma, improve access, and identify problems early, support use of often purchasing of technology, so we get to the most remote places with telehealth, telemedicine, those kind of things, something that we are doing already. Training and technical assistance, workforce education and training, and there is specifically a pot of $60 million statewide project specifically for ethnic groups, as to what some innovative approaches that will come out of that. And this is, there is a lot of things happening, and this is the one that I was talking about. That there are some set aside money to ethnically and culturally specific programs. This is what is happening. 50 million annually for 4 years, a total of $60 million to deal with these issues, that I was talking about. This is a great opportunity for us, and I hope that something similar takes hold, in a place like Texas, certainly in the border region. Okay, to conclude, disparities in access to and quality of care are evident, common, and pervasive. Ethnic group differences exist in access to and utilization of services, and these differences appear to be worsening in for Latinos. A large burden of untreated illness in Latinos. This burden is associated with unemployment, leads to lost productivity and lack of economic prosperity. Latinos are typically disengaged from health care with limited opportunity to take charge of their care. This leads to low retention in care. Multi-tier strategies focusing on culture and language and attention to quality care hold promise. Prevention and early intervention services hold promise for reaching Latinos who may fear stigmatization if they seek mental health services. And it seems to us there is a growing desire among key mental health care stakeholders for concrete solutions about these issues. And when it comes to the border, this is critical. Mexicans who immigrate to the U.S. have good health and mental health. Persistent migration implies the need for permanent, collaborative, and efficient health promotion, prevention, and treatment programs. We need collaboration from public and private sectors at the local, regional, national, and binational levels. And we cannot do it alone with isolated efforts. We need to continue to join efforts to remain healthy. This is in no ways an effort that I have done it by myself. I have a wonderful team that I have worked with, wonderful partners in different agencies. So this has been a collective effort. And finally, just to leave you with this quote, we shall have all of eternity in which to rest. Now let us work for their sake and ours. Is in love with her man, with this man, and would love to keep this kind of incredible connection healthy, for the rest of their lives. If that doesn't happen, this is what's going to happen. Okay, but I prefer that something like this happen, to get them early into education. This is my grandson.
Let's give it a
Thank you.
We have 2 minutes to engage in some have some questions, if you would like to raise some questions, and then we can go for a nice 15-minute break. Thank you, all of you. So anybody has any questions? Like to engage them?